Welcome back to the deep dive. Today we're tackling, well, a pretty dense topic, the pharmacology of women's health.
It really is. There's a lot here.
Our mission is basically to cut through the complexity, give you a clear summary of the key drugs from the Lilly chapter, mechanisms, uses, and especially those critical nursing points. Consider this your shortcut.
Exactly. And we're covering a wide range: hormones, HRT, contraception, even osteoporosis, fertility, and drugs used during labor and delivery. It's quite the spectrum.
Okay, let's start at the beginning then, the foundations. To really get these drugs, we need a quick refresher on how female reproduction is orchestrated, right?
Right? It's all about signals from the brain, specifically the pituitary gland. It sends out FSH and LH, the gonadotropins.
And those gonadotropins talk to the ovaries.
Precisely. They tell the ovaries to produce the main sex steroid hormones, estrogens and progesterone.
Estrogen, primarily estradiol, you mentioned.
Yes, estradiol is the main one. It drives the development of secondary sex characteristics, but crucially, it also talks back to the pituitary. It regulates its own levels through feedback.
A self-regulating system. And progesterone, what's its main role?
Think of progesterone as the progestation hormone. It's made by the corpus luteum, that's the structure left after ovulation.
Okay.
Its job is to prepare the uterine lining for a possible pregnancy, make it nice and receptive. And, really importantly, it keeps the uterus quiet, inhibiting contractions during pregnancy.
Makes sense. You wouldn't want contractions early on. And we should probably quickly define menopause, too.
Good point. Menopause is formally defined as the cessation of menstruation for a full 12 consecutive months. Understanding that natural drop in hormones is key to why we use some of these drugs.
Right. So let's dive into the drugs themselves, starting with therapeutic estrogens.
Okay, so the natural estrogens your body makes, they don't work well if you take them orally. They get broken down too quickly.
Ah, so we use synthetic versions.
Exactly. Synthetic or steroidal ones. You'll see conjugated estrogens, like Premarin. Historically, that actually came from pregnant mare urine.
Wow, really?
Yeah. Though nowadays, many versions are derived from plant sources like soy or yams. Caniston is an example.
Hmm.
And then there's ethinyl estradiol, which is very potent and super common in birth control pills.
We should probably also touch on DES, diethylstilbestrol, shouldn't we? Just briefly, given its history.
Yes, absolutely. DES was a non-steroidal estrogen used quite a while ago, thought to prevent miscarriage. But tragically, it caused devastating reproductive problems, even cancers, in the daughters of women who took it during pregnancy.
A really stark reminder of long-term drug effects.
The profound lesson in pharmacological safety, definitely.
So today, what are the main uses for prescribed estrogens?
Primarily for managing moderate to severe menopausal symptoms, especially those disruptive hot flashes. Also sometimes for conditions like hypogonadism or for preventing osteoporosis, though that's like common now.
And that leads us to the big turning point, the Women's Health Initiative, the WHI study. That really changed things for hormone replacement therapy, didn't it?
Oh, completely.
Yeah.
It was a landmark study. It basically debunked the idea that HRT was a good general strategy for preventing chronic diseases in all postmenopausal women.
What were the key findings that caused such a shift?
Well, the WHI found that combination estrogen-progestin therapy actually increased the risk of breast cancer, stroke, and dangerous blood clot.
Increase the risk?
Wow, yes. And even estrogen-only therapy, which was given to women without a uterus, showed an increased risk of stroke.
So the takeaway now is much more cautious.
Absolutely. Current guidelines are clear. HRT should be individualized, used at the lowest effective dose for the shortest possible time, and it's really only indicated for managing significant menopausal symptoms. It's not recommended for preventing heart disease or dementia.
Okay, so safety first. If someone is on estrogen therapy, what are the major warning signs they need to watch for?
The absolute most serious risk is thromboembolic events, blood clots. So any severe headache, sudden visual changes, chest pain, shortness of breath, or leg pain needs immediate medical attention.
Got it. Anything else common?
Nausea can happen, sometimes hypertension. And one specific thing is cloasma. That's a brownish discoloration that can appear on the face.
Okay. Let's shift gears to progestins. Medroxyprogesterone is a common one.
Right. Progestins are used for various things, managing dysfunctional uterine bleeding, treating amenorrhea, obviously in contraception. And then there's Magestrol, which has a unique use.
Oh, yeah, you mentioned appetite stimulation?
Exactly. Magestrol is sometimes used to combat cachexia, that severe wasting you see in some AIDS or cancer patients. It helps stimulate appetite.
Interesting. What about Depo-Provera? That's the injectable progestin, right?
Yes, medroxyprogesterone acetate injectable, Depo-Provera gives 3 months of contraceptive cover. Very convenient for some.
But there's a major warning with that one.
There is. It carries a significant black box warning regarding loss of bone mineral density. This is a real concern, especially with long-term use, say over 2 years, or in younger women under 25 who haven't reached peak bone mass yet.
So bone health is a key consideration before starting Depo-Provera.
Definitely. A thorough assessment is needed. And like estrogens, progestins also carry a risk of thromboembolic disorders and potential liver issues.
Okay, let's move on to the most common use of these hormones for many people, contraceptive drugs.
Right. And the first thing to stress, always, is that while oral contraceptives are extremely effective at preventing pregnancy,
They offer zero protection against sexually transmitted diseases.
zero. That needs constant reinforcement. Now, there are different tubs of pills.
Right, the phasic ones.
Yeah, monophasic pills have the same fixed dose of estrogen and progestin throughout the cycle. Biphasic pills keep the estrogen steady, but increase the progestin in the second half.
And triphasic.
Triphasic pills vary the doses of both hormones in 3 distinct phases. The idea is to more closely mimic the natural hormonal fluctuations of the menstrual cycle. There are also extended cycle pills designed to reduce the frequency of periods.
How do they actually work? What's the mechanism?
The primary way they work is by suppressing ovulation. They inhibit the release of those gonadotropins, FSH and LH, from the pituitary.
So the brain doesn't send the signal to release an egg.
Exactly. No egg release, no pregnancy. But they have backup mechanisms too. They thicken the cervical mucus, making it harder for sperm to get through.
A double barrier, essentially.
Pretty much. And they might also alter the uterine lining to make implantation less likely, though ovulation inhibition is the main thing.
Now, this is probably one of the most critical pieces of patient education for oral contraceptives, the drug interactions.
Absolutely crucial.
Yeah.
And often missed. Certain common medications can significantly reduce the effectiveness of birth control pills.
Meaning an increased risk of unintended pregnancy.
Exactly. The big culprits are certain antibiotics, especially penicillins and cephalosporins, also the TB drug rifampin, and even the herbal supplement St. John's wort.
So what's the advice for patients taking these?
They must use a backup method of contraception, like condoms, while taking the interacting drug and for at least 1 full month after starting it to ensure protection is restored.
That's vital information. And there's another major warning associated with all oral contraceptives, right? The black box warning.
Yes, and it's serious. It concerns cigarette smoking and the risk of serious cardiovascular events, heart attack, stroke, blood clots.
And that risk goes way up if you smoke.
Dramatically, especially for women over 35 who smoke. It's an absolute contraindication for many and a critical discussion point for any smoker considering the pill.
Okay, definitely highlights the need for thorough patient history. Now, talking about long-term risks and hormonal changes brings us naturally to osteoporosis.
Right. Osteoporosis is that progressive loss of bone density, making bones brittle and prone to fracture. We have several classes of drugs to treat it, often used alongside calcium and vitamin D supplements.
And the main players are the bisphosphonates, like alendronate.
Yes, alendronate. Fosamax is a common brand name, is a classic example. Bisphosphonates work by inhibiting osteoclasts.
The cells that break down bone.
Exactly. Osteoclasts resorb old bone. By inhibiting them, bisphosphonates allow the bone-building cells, osteoblasts, to catch up, leading to increased bone mineral density. They can actually help reverse bone loss.
Okay, and this drug class has that incredibly specific administration rule. You hinted at it earlier.
It's probably the most crucial nursing point for this drug. If you remember one thing about alendronate, this is it.
What is it?
Because of the risk of severe irritation, erosion, or even burns in the esophagus, the patient must take it first thing in the morning on an empty stomach with a full 6 to 8 ounce glass of plain water. Not juice, not coffee, just water.
And that's not all, right?
Nope. After swallowing the pill, they absolutely must remain sitting or standing, fully upright, for at least 30 minutes. No lying down, no slouching.
30 full minutes upright. Why?
To ensure the pill travels quickly through the esophagus and down into the stomach. If it gets lodged in the esophagus, it can cause serious damage. Compliance with this is absolutely non-negotiable for safety.
Wow. So if someone can't sit upright for 30 minutes, maybe they're bedridden.
Then this drug is likely not appropriate for them, or the dose might need to be held. It's a major consideration.
Okay. What other options are there for osteoporosis? You mentioned
Right.
SERMs.
Selective estrogen receptor modulators like raloxifene, the name selective is key.
How so?
They act like estrogen on bone tissue, stimulating those estrogen receptors to help increase bone density. But, and this is the selective part, they block estrogen receptors in other tissues, like the breast and uterus.
So you get the bone benefit without some of the risks associated with broader estrogen activity.
That's the idea. It offers a more targeted approach.
Are there still risks with SERMs?
Yes. Common side effects include hot flashes and leg cramps. But more seriously, like estrogens, they do increase the risk of venous thromboembolism DVT and pulmonary embolism.
So similar clotting risk. Anything specific related to that?
Yes, a really important point.
Yeah.
Raloxifene needs to be discontinued at least 72 hours before any period of prolonged immobility. Think long plane flights, major surgery, or prolonged bed rest. You need to stop it temporarily to reduce that clot risk.
Good to know. And briefly, calcitonin.
Calcitonin is another option. It also inhibits osteoclastic bone resorption. It often comes as a nasal spray. The main thing to note is that it's typically derived from salmon, so you need to assess for any fish allergy, specifically salmon allergy, before use.
Okay, salmon allergy check for calcitonin. Got it. Let's pivot now to the really high-stakes area.
Right.
Drugs related to pregnancy, labor, and delivery, starting with fertility drugs.
Right, like clomiphene. This is often a first-line treatment for infertility due to ovulation issues.
How does it work? Is it a hormone itself?
No, it's actually a non-steroidal ovulation stimulant. It works by blocking estrogen receptors in the brain, specifically the hypothalamus and pituitary.
Blocking estrogen receptors, how does that stimulate ovulation?
Well, by blocking those receptors, it basically tricks the brain into thinking estrogen levels are really low. The brain responds by pumping out more GnRH, which in turn tells the pituitary to release more FSH and LH.
Ah, so it overrides the normal feedback loop to boost the signals for follicle development and ovulation.
Exactly. It ramps up the stimulation.
What's the major downside or risk with using clomiphene?
The biggest risks are multiple pregnancy twins, triplets, or even higher order multiples are significantly more common, and something called ovarian hyperstimulation syndrome, OHSS, which can be serious.
Okay, now moving into labor itself. Uterine stimulants or oxytocics. Oxytocin or pitocin is a huge one here.
Absolutely huge and classified as a high alert medication for very good reasons.
High alert meaning high risk if used incorrectly.
Precisely. Oxytocin is used to induce labor, when medically necessary, to augment or strengthen labor that isn't progressing electively, and also, crucially, to prevent or control bleeding after delivery.
And it's usually given intravenously.
Yes, typically as a carefully controlled IV infusion. Its effect is almost immediate, which is why the dose has to be titrated, meaning adjusted very carefully, based on how the uterus is responding and how the baby is tolerating the contractions.
So constant monitoring is key.
Mandatory. Continuous monitoring of the mother's blood pressure, pulse, the frequency and duration of contractions, and the fetal heart rate is absolutely required. You cannot just hang it and walk away.
What are you watching for as signs of trouble?
You're looking for uterine hyperstimulation. That means contractions are coming too close together, say more often than every 2 minutes, or lasting too long, maybe over a minute, or any signs of fetal distress on the monitor.
And if you see those signs...
Stop the infusion immediately and notify the provider. Patient safety depends on vigilance here.
Okay. What about other drugs used to get labor going, like prostaglandins?
Right. Prostaglandins like dinoprostone are used primarily for cervical ripening,
Yeah.
basically softening and preparing the cervix for labor induction. They often come as a vaginal insert or gel.
I've heard misoprostol's also used.
Yes, misoprostol is actually a prostaglandin E1 analog. It's technically approved for other uses like preventing stomach ulcers, but it's very commonly used off-label for cervical ripening and labor induction because it's quite effective and significantly cheaper than dinoprostone.
Interesting. And then after the baby and placenta are delivered, there are drugs for postpartum hemorrhage?
Yes, the ergot alkaloids, like methylorgonavine. These are used after delivery to cause strong uterine contractions, clamp down on blood vessels, and control postpartum bleeding. They enhance that muscle tone in the uterus.
Is there a major contraindication for those?
Absolutely. They are strictly contraindicated in patients who have hypertension, especially pregnancy-induced hypertension or preeclampsia, because they can cause a dangerous spike in blood pressure, potentially leading to stroke or seizures.
Okay, very important distinction. Now, what if labor starts too early? Drugs for preterm labor.
Those are called tocolytics. The goal is to stop or slow down uterine contractions, typically used between weeks 20 and 37 of gestation to try and delay delivery.
What drugs fall into that category?
Several classes. Indomethacin is an NSAID that inhibits prostaglandin synthesis, which can relax the uterus. Nifedipine, a calcium channel blocker, can also relax uterine smooth muscle.
And magnesium sulfate.
Magnesium sulfate is another commonly used tocolytic, although it's also considered high alert. It works by relaxing smooth muscle. However, the FDA has issued warnings against prolonged 5E use of magnesium sulfate and also against using terbutaline long-term for preventing preterm labor due to serious maternal heart problems. So use is typically short-term and very cautious.
Wow, that whole sequence from fertility to postpartum really underscores the need for careful assessment and monitoring, which brings us perfectly to the nursing process.
Exactly. How do we apply all this knowledge safely? It starts with a thorough assessment. Before initiating any hormonal therapy, especially estrogens or progestins, you need baseline data.
Like what specifically?
Definitely blood pressure and weight. You need to know their history. Have they had blood clots before? Any estrogen-dependent cancers? Undiagnosed vaginal bleeding is a big red flag. Also check when their last pap smear and breast exam were.
Okay, thorough baseline. And then during implementation, any key tips?
For oral hormones, taking them with a meal or a snack can really help minimize GI upset, like nausea. And consistency is key. Take them at the same time every single day.
And for those bisphosphonates, like alendronate?
Reinforce that 30-minute upright rule with a full glass of water. It cannot be stressed enough.
And for oxytocin infusions?
Continuous vigilant monitoring. That's the mantra. Maternal vital signs, contraction pattern, fetal heart rate constantly assessed. And knowing when to stop the infusion immediately is critical.
Finally, evaluation. What should patients be told to report immediately? What are we monitoring for?
This ties right back to the adverse effects. We need them to report signs of fluid retention, like sudden weight gain, maybe 2 pounds in a day or 5 pounds in a week.
Okay.
Also, those signs of potential clots or hypertension we mentioned, severe unusual headaches, any visual disturbances, chest pain, shortness of breath, or significantly elevated blood pressure. Any breakthrough bleeding or unusual pain should also be reported right away.
It really closes the loop. Understanding the risks informs what you monitor for.
Precisely.
This has been incredibly helpful, really drilling down into these important drug classes. We've covered the huge impact of studies like the WHI, the balance of power and risk with hormones, and those absolutely critical administration details like the alendronate posture patrol.
Right. And the high alert nature of drugs like oxytocin really stands out.
It does.
And thinking about alendronate and that upright rule actually brings us to our final thought for today.
Oh,
Yeah, we know that bisphosphonates like alendronate can actually get incorporated into the bone matrix and potentially stay there for more than 10 years. Because of this potential long-term accumulation, experts often recommend limiting continuous therapy to around 5 years.
okay, so limit the duration because it sticks around in the bone for so long?
Exactly. So the question to ponder is, for patients who might need lifelong protection against fractures due to severe osteoporosis, what kind of future drug strategies might we see? How could we manage osteoporosis long-term without risking the potential issues of having a drug accumulating in bone tissue for decades?
That's a fascinating challenge. Managing chronic conditions without long-term accumulation risks? Definitely something to think about.
Food for thought. Thank you, everyone, for joining us on this deep dive into women's health pharmacology.
Yes, thank you for tuning in.